People should not depend on ABO. They should come to the hospital. When you feel something you don't understand, come to the hospital so that you get a better checkup and treatment. That is how I've survived.
Mangu nnyo ng'omuntu oludda bakantu kakutteko ku bulamu bwo ojje weekebeze kijja kuwa buki kijja kuwa obwangu bw'okujjanjaba buli ojja amangu mu ddwaliro ne bakebera obulwadde ne babulaba bwe ne babulaba mangu naawe osobola okuwona amangu.
Last time, we traced the heartbeat of Mulago's government-run endoscopy unit. Today, we cross the threshold into a realm where cutting-edge technology meets international collaboration. The South Korea-Uganda partnership that is redefining gastrointestinal care. Funded by the governments of Uganda and South Korea, this unit is more than bricks and mortar. It's a bridge of expertise, a promise of precision medicine for every patient who walks through these doors. Every machine is calibrated to the highest international standards, a testament to a partnership built on trust and shared knowledge.
When you see this is the small caliber and short, right? This is the upper GI endoscope. So we have 3 upper GI endoscope, and we have somehow cheap one. We have a high endoscope. So cheap one is around 40 million. It's very cheap. Oh, this one high end is like 65 million, 70 million like that. And we have 2 colonoscope also, high end and then normal. So this one is more expensive, like 5 to 10 million than the upper GI endoscope. And then we have also the dual channel scope. Dual channel scope, this is the dual channel. So we are using 2 working channel for the therapeutic. So this one is, I think we have only we have in Uganda. Yeah, so we are using for the therapeutic because we are doing the all therapeutic procedures. This one also around 70 million around there. And we have a side duodenoscope for ERCP. Yeah. This is a side duodenoscope. You see, the lens is side. So this is for ERCP, for the biliary system or pancreatic system. This is not very expensive. This is like 50 million, 55 million, like that. And then we are doing the standard disinfection process. This is the auto washer for the endoscope. So this one, so we put before putting into the machine, we wash by the hand the channel or the working side well, and we connect with the machine. And then this one has a cycle, initially washing, rinse, and then by the air pushing, and we are using the Sidex because this is not sterile, this is the high quality disinfection. So we use the Sidex and then again rinse and air, and we dry well. So we are using 2 machines, yes.
Our first patient is a 20-year-old man who vomits blood frequently and also suffers from persistent inflammation.
So this 32-year-old man vomited blood 4 times, In medical term, we are saying the hematemesis. So they transfuse the 4 unit from the medical ward, and then they consulted us to do upper GI endoscopy. So we will find out what was the exact cause for the vomiting blood. Okay? Yeah.
Under Dr. Cheng's deft guidance, tissue samples are taken to test for pyralin, an inflammatory marker whose early detection can alter the course of treatment.
So this 32-year-old man vomited blood 4 times. In medical term, we are saying the hematemesis. So they transfused the 4 unit from the medical ward, and then they consulted us to do upper GI endoscopy. So we will find out what was the exact cause for the vomiting blood. Okay? So this is the vocal cord. So our endoscope is the cutting edge endoscope, high technology. So we are using the water pump also, water injection, like this. So asparagus was okay, and then this is the junction between asparagus and stomach. Now the junction has some mild inflammation. The line is not very clear, so we are calling it reflux esophagitis minimal change. So this fluid is mixed with the bile and then gastric juice. You can see the greenish, right? Yes. There is the gastric juice and then bile from the liver.
Okay.
So this is the stomach, the part of the antrum and pylorus. And then you can see the nodularities, right? Like a chicken skin.
Yes, I can.
So this is caused by usually by the Helicobacter pylori infection. And we are entering the duodenum. Okay, this is the duodenum. There is some inflammation plus. So this is the duodenum second portion. Very inflamed hole, I can see the ulcer. Because he vomited blood. So there is inflammation in the first portion. You can see.
Yes, I can see.
Yes, this is the first portion. However, I can see the duodenal rear ulcer. Okay, so now we are observing the stomach more, and this is the lesser curvature side.
All right.
I did the J-turn.
All right.
We are observing. I think this mucosa, when you vomit it, is entrapped to the esophagus. That's why the erythematous change happens. You understand that?
Okay.
So this is the image. So this is the gastroesophageal junction. I did J-turn, and there is the scope.
Okay.
You can see the inflammation here also, and then you can see the reddish line.
Sure.
Yeah, we are calling it hyperlamic strain or strix. That is superficial gastritis. So this reddish inflammation is the one we did data. So we took the tissue from stomach, the antrum, and the body. Two tissue we put, and if Helicobacter pylori has a urease, so it changes the color from yellow to red. So this 34-year-old female examined by the CT scan, and they suspect the ascending colon, right side colon mass. So they want us to do colonoscope and see the tumor is there or not, and to do biopsy, because usually the cancer diagnosis is confirmed by histology examination.
Next, a routine colonoscopy unearths multiple swellings, critical clues that will dictate the next phase of her care. For patients like Jacqueline, the clinic's empathetic approach is as vital as its advanced tools.
Okay, so we did this patient previously. She had two esophageal mass. So after diagnosis, and we did endoscopic mucosal resection and then endoscopic submucosal resection. This is shows. So there was a mass here, and another one is there. So we removed by endoscopy. So you can see the margin was clear. So it was last year, December. So today we followed up the reason. Okay.
So the follow-up is also with an endoscopy?
Yes. So I don't, you see. So this is the esophagus. It's okay. This is the esophagus. So we are observing. So this is the first scar we removed by the endoscopic mucosal resection. 27 centimeter from upper incisor, because the measurement of length is very important. We are doing the standardization. And then another scar, you can see another scar? Yes. This is the 30 centimeter from upper incisor, and it was big. So after resection, we apply the clip 5. So usually clip after healing is going off. However, this one is still remain. This one with passing time, this one will also will go off. So there was no recurrence. It's very healed very well, no more mass. So both were very okay. Yeah. That is the result. However, you have some mild inflammation in the junction between esophagus and stomach. So sometimes you feel the heartburn, right? Yes, that's why. So, yes, so important thing is you need to reduce taking coffee, chocolate, alcohol, and then, yes, and then after taking meal, especially dinner, don't take lying position within 3 hours. So when you take the dinner and when you take the lying position, sometimes some loose area allows to go of the food materials and the gastric juice. And then you are feeling the heartburn. And after waking up, you are feeling some feeling of the foreign body sensation and the hoarseness. Those ones goes like that. And another thing is, so your duodenum was okay. This is your stomach. When you see there is some reddish line and there's some erythema there, and then some small wound, okay? So those small wound, it looked not bad. However, for confirmation, I took the biopsy and we'll see the result. So we need to see, is it just the normal inflammation only or some bad cell there? So I took biopsy like that, and we'll see the result. Usually it will take 3 working days. Yes, and I'll give some medication also. Okay. Okay. After taking biopsy, I confirmed the normal bleeding. I injected some epinephrine injection. Yes.
I'm called Adong Jacqueline. The first time I came here, I was feeling so bad. I was feeling a lot of, like my throat is blocked and I cannot also sleep. When I eat something, I feel like throwing it out. Even water, they have been telling me it's ulcers, but some doctor advised me to come here for endoscopy. When I came here, I have to sit when my chest is up so that I can breathe well. Now, they booked me. After a week, I came back. They did the endoscopy and checked. They found that I have a mass, and there were 2. In the esophagus. Yes. One was big, one was a bit smaller, and the bigger one is the one blocking the way for food. I was not okay. I was not eating. I lost weight. After the operation, they did the operation after a week after the checkup. After the checkup, operation, I came back here, they did the operation. I went back home. I stayed for like 2 weeks taking black tea. After taking black tea, I started taking a little bit of porridge. Then after that, I started taking soup.
During that time, you don't take any serious food?
No.
Solid food?
No.
Just liquids?
Liquids. It was not easy. I had a lot of pain after the operation. Then, like after a month, I started feeling better, but the weight was not okay. I was very small. After 2 months, I started gaining. I started feeling better. I can even walk alone. I was not walking alone. This was a good doctor. He did a very good job on me, and I appreciate it.
His journey underscores a simple truth. Technology may open new frontiers, but compassion guides the way.
Mwezi gw'omwenda n'ogw'ekkumi nali siba mulamu, naye wallahi Mungu yayisiza ku musajja oyo. Omusajja yanziza mu sweta emirundi egi nga bigaana, naye nga gwazzaayo nga zinalinga oluti bwe lunene kati ambaaso ojja kudda engulu tugende, naye nga kyende kigaanye okuleeta ng'obulumi buluma okufa obufi. Naye Mungu n'asaasira, omusajja n'annongoosa bulungi nnyo, n'abaana abawala abo nga lubonibode tulina abo tunyumya abo nga bakola omulimu gw'amaanyi nnyo. Mungu mbeebaza abawa obuwangazi obulungi, ababeere nti nno omulimu gwe bakola Mungu abateeremu okwagala ng'omusajja oyo. Singa sino twali twagala nga abasajja abazungu abo bakolagana omuntu nga baagala obulamu bw'omuntu, twandibadde mutuufu tetubaako kufa nnyo. Naye Mungu abasaasira abasajja, n'omusajja oyo kyanga Mungu amusaasire, amutuwangaalize. Mu Uganda mutugere nga tukyalina abasajja abo nga bano 10. Mungu asobozese Rabbi tubeeremu.
Precision is nothing without care. These nurses are the clinic's heartbeat, ensuring each patient moves from anxiety to assurance. From the endoscopy tip to healing hands, this partnership unit exemplifies what's possible when nations unite around a shared goal, saving lives, restoring dignity.
we usually use the two kinds of solution. So first one is PEG solution, polyethylene glycol. So we usually give the 2 liter. So they are taking 1 liter over 1 hour slowly and add 500 cc water, and then they will start the diarrhea 1 hour or 2 hours later. We usually start around 6 p.m. the day before. And the second dose, same amount in the 5 a.m. or 6 a.m. on the day. So polyethylene glycol. Another one, we can use the sodium phosphate solution. It is called here ColoPrep. So we use the PEG solution or sodium phosphate solution. And then usually the function is it draws the water into the colon, and then it starts diarrhea. And because if the stool is there, we can't observe well.
Yeah, I saw.
Patient can have epigastric pain or abdominal pain or heartburn or sometimes nausea, vomiting, bloating, dyspepsia. Those things indicate for the apogea or the vomiting blood. And another thing is the passing blood like hematochezia or the constipation, and then bowel habit change. It means the previously bowel came with a good caliber. However, recently the stool caliber is narrowed like a pencil-like or something, and then some patient can have a constipation. In this situation, we need to confirm those constipation is not caused by mechanical cause like a tumor or luminal narrowing, or patient has a diarrhea or something. We need to do colonoscopy. And then for the ERCP, if a patient has a periumbilical pain radiating to the backside, or patient has a LOI, which is called jaundice, those things are indication, or patient has a itching sensation, yes, those things. For example, for the colorectal cancer, about 70% colorectal cancer comes from polyp, small polyp, and when you take it, the histology says adenoma. That means with some bad cells. So from those adenoma to the carcinoma, those sequence, adenoma, carcinoma, the sequence explains 70% colorectal cancer. That means when they do regular screening or do endoscope, 70% colorectal cancer can be preventable. Okay. Or we can detect very early stage and the outcome is very good. And apogea endoscope also, here, esophageal cancer are very many than the stomach cancer. So when they feel some discomfort, when they visit, we can do early detect, and we can do treat by the endoscopically. Yes. However, usually the problem is Ugandan patient show up to the hospital very late. Usually when they can't eat well, when they can't swallow well, or when they vomit, and when they can't pass the stool, or they have intestinal obstruction. So they need to be alert about the symptom. That when they visit earlier, it's very easy to be treated. And then those things will decrease the total medical cost actually.
UBC, inspiring Uganda. Brought to you by
Youth, elderly, and persons with disabilities. It's time to choose our leaders. Let's show up and participate in the special interest group elections starting